Hello everyone. In this video, we will talk about the drugs used for mania and for bipolar disorder. And like all other pharma videos, the video notes for this lecture will be available for free download from the app. So this mental illness we have seen in our previous video on antipsychotic drugs, where we said that the mental illness is broadly classified as psychosis and neurosis, and in psychosis insight of the disease is absent. The patient is not in touch with the reality, and this we saw about the schizophrenia or paranoia in the antipsychotic drugs. Now today we will talk about mania and manic depressive psychosis, that is the bipolar disorder. Depression will be another video. So now when we talk about this mania and manic depressive psychosis, we are talking about the drugs, that is mood stabilizers. What is this mood stabilizers? Basically, if you see, this line represents the stable mood, and if the person is too much elated, then that is mania, and if the mood is too much down, then it is known as depression. And in mania, actually the main problem is increase in the dopamine levels, while in depression the main problem is decrease in the norepinephrine levels. So in mania, only if we talk about mania, then it is always too much elated mood. The person will spend a lot, he will talk a lot, there will be flight of ideas, he will be restless, there is decrease in sleep, decreased contact with reality. So that is mania. But generally, this mania is not seen as separate disease. It is very rare in that case, but generally it is seen as cycles of mania and depression, and that is known as bipolar disorder. Okay, so we have acute mania where that mania phase is there, and then most commonly this mania is seen in bipolar disorder. In bipolar 1 disorder, we have mania with depression. However, in bipolar 2, we have hypomania. That means that much grave disease is not there, that much elation of mood is not there, but depression is major problem with the bipolar 2 disorder. Okay. So with this, let us talk about the mood stabilizers. So we have the drugs which can be given in acute mania or in the manic phase of the bipolar disorder, and then we have drugs which are given for prophylaxis in bipolar disorder. And remember that these mood stabilizers, it is not that they decrease the mood of the person or make him depressed when the person is having acute mania. Basically, mood stabilizers mean that it prevents too much swing of the mood on either side, not too much elated, not too much depressed. So that is stabilization of the mood. So these mood stabilizers prevent abnormal mood fluctuations. So we have drugs for acute mania which include lithium, valproate and carbamazepine, and there is antipsychotic. So valproate and carbamazepine are basically anti-epileptic drugs which are used as mood stabilizers as well. However, carbamazepine is not much used because response rate is lower, but if the patient is not responding to lithium, then in that cases it may be used, and then there are combination therapies. Then for prophylaxis in bipolar disorders, we have certain drugs. Let us talk about these drugs, then we will go into details about lithium because that is the special drug here. So, for acute mania, drug of choice is lithium, which is given with benzodiazepines, or it can be combined even with antipsychotics. Okay, so lithium is not given alone for acute mania because it is slower acting, and it takes some 1 to 2 weeks for effect to take place. So for acute mania, we want fast action. That is why we give lithium along with the benzodiazepines or with the antipsychotics. Then we also have valproate. Now remember, this valproate is the drug of choice for bipolar disorder in patients having rapid cycles. So when we talk about rapid cycles, cycles means basically number of times the mood is swinging to either side per year. Okay, so if the patient is having rapid cycles, that means these mood swings are happening more than 4 times per year. That is known as rapid cycles, and in those cases valproic acid becomes a drug of choice, right? Then we have antipsychotics. As I told you, antipsychotics are combined with lithium for having the maximum benefit with the lithium because lithium is slower acting, right? Then we have prophylaxis in bipolar disorders. So in this, lithium is the drug of choice for bipolar 1 disorder. So for the prophylaxis in bipolar 1 disorder, that is mania plus depression, lithium is the drug of choice. On the other hand, in bipolar 2, in which the major problem is the presence of major depression. Mania is not that severe, it is hypomania. So in that case, we give lamotrigine because this lamotrigine has greater effect on depression relapse. Okay, so bipolar 2 disorder, lamotrigine is a drug of choice, right? And atypical antipsychotics can also be given. Now, one more thing, that for acute mania, actually higher doses of drugs are required. So same atypical antipsychotics which can be given for acute mania, also for prophylaxis, higher doses are required during acute mania. Same is the case with lithium, right? So let us go in detail now about lithium, because this is a special category drug here. Rest of the drugs, when we talk about the anti-epileptics, I have covered in the video on anti-epileptics. Similarly, antipsychotics I have covered in the separate video on antipsychotics. So what is this lithium and how does it act? So lithium basically acts in hyperactive neurons only. That is very important. Okay, it is in the hyperactivity of the neurons causing increased release of the dopamine. It prevents their action. How? So what happens that on these neurons there is these GQ receptors. So any agonist which can bind on these GQ receptors. GQ receptors, we know from our basic physiology knowledge that they increase the activity of phospholipase C enzyme, which in turn acts on the membrane lipid, that is phosphatidylinositol biphosphate. So this phosphatidylinositol biphosphate is broken down to IP3 and DHE. IP3 acts on its receptors present on the mitochondria, causing release of calcium. So in total, basically there is release of calcium within the cell. Now this calcium release will cause increased release of the neurotransmitter. Calcium is responsible for the fusion of the vesicles, and these vesicles will fuse more, cause increased release of the neurotransmitter. Now, if we prevent this, that means this neurotransmitter release will go down. We have to decrease the release of dopamine, we have said, right? So this is prevented by lithium. How? See, this IP3 inositol triphosphate is broken down to inositol, which is again utilized for the synthesis of this membrane protein PIP2. So this lithium basically blocks this recycling. Okay, so that inositol is not formed. Inositol is formed less, and once it is formed less, PIP2 will be synthesized less, and that means further cycles of IP3 generation, calcium increase within the cell, they are not going to occur, and that is going to decrease the neurotransmitter release, right? So remember this, that lithium acts only in hyperactive neurons, prevents the regeneration of phosphatidylinositol biphosphate, so that IP3 is formed less and neurotransmitter release, that is dopamine, is released less. So what are the uses of lithium? First thing, very important, that lithium has narrow safety margin. Narrow safety margin means when we are giving the drug, we cannot just increase the dose just like that. We have to monitor the serum levels so that they do not go beyond a critical level, right? Now, for acute mania, serum levels, the therapeutic serum levels are between 0.8 to 1.2 milliequivalents per liter. For prophylaxis of bipolar disorder, where it is the drug of choice, which I told before, bipolar disorder 1, the serum levels are between 0.5 to 0.8 milliequivalents per liter, and this is important for you to remember. Okay, because if the levels go above 1.5 milliequivalents per liter, we start getting lithium toxicity, right? So acute mania, I told you before that the dosage required is much more. So that is why here serum levels are more than that required for prophylaxis in bipolar disorder, right? Acute mania, serum levels between 0.8 to 1.2 milliequivalents per liter. Now, once the patient becomes euthymic, that is the normal mode has come, then you have to start decreasing the dose, so that now the serum levels are between 0.5 to 0.8 milliequivalents per liter. Then It is slow to act, so give along with antipsychotics or with the benzodiazepine. They take 1 to 2 weeks for effect. Their T half is 24 hours. Okay. Then for prophylaxis of bipolar disorder, yes, they are drug of choice and they are the only drug which have shown decrease in the suicidal tendencies. Yes, okay, only drug. So even though there are other drugs which can be used for prophylaxis, but lithium is the only drug which has shown decrease in the suicidal tendencies during the depression phase of bipolar disorder. Okay. Then third use of lithium is that they can be used for resistant cases of unipolar depression. Okay. So for unipolar depression, we have different drugs like SSRIs are there that we are going to talk in separate video. But if the patient is not responding to those drugs, then in that cases, that is the resistant cases of unipolar depression, lithium can be used. Okay, unipolar depression means that the patient is suffering only from depression. He is not a patient of bipolar disorder in which mania also occurs. Okay, now the mechanism of action for depression is thought to be different. Basically, this lithium inhibits an enzyme GSK3, okay, glycogen synthase kinase 3, which degrades BDNF, okay, brain derived neurotrophic factor. Now, this lithium inhibits this GSK3 enzyme and causes the accumulation of this neurotrophic factor, and that is postulated as the mechanism of action in unipolar depression. Right. Now, what are the drug interactions? For this, you remember one thing, that lithium is handled similar to sodium in body. Okay, so wherever sodium is going, lithium is also going. The transporters, in fact, for sodium, they can also bind with lithium, except sodium potassium ATPase. Okay, so what are the drug interactions? See, in the kidney, we know that the ions are filtered. So, sodium is filtered, lithium is also filtered, but sodium is being reabsorbed in the proximal convoluted tubule, right? 65 to 70% is reabsorbed in the proximal convoluted tubule. Now, if we give certain drugs, that is the diuretics, sodium excretion increases. Now, since lithium is handled similar to sodium, actually during this reabsorption process, it competes with sodium for reabsorption. If there is sodium excretion, too much sodium excretion is there, then there is decrease in this competition, and instead of sodium, we get increase in the lithium reabsorption. So that is going to cause toxicity. Okay, we know that if there is a very narrow range in which the lithium serum levels are maintained. Now, because of the presence of diuretics, there will be increase in the lithium reabsorption and the serum levels of lithium are going to increase. Okay, same is the case with NSAIDs and same is the case with ACE inhibitors. They all increase the lithium reabsorption. Okay, and for which patients these drugs are generally used? Cardiac patients, diuretics and ACE inhibitors, they are being used for cardiac patients or hypertensive patients. And if a patient who is on lithium, say suppose he becomes hypertensive and you add ACE inhibitor, then there are chances that there will be increase in the lithium serum levels causing lithium toxicity. So we have to be careful in such cases. Then second is hyponatremia. Okay, hyponatremia also causes increased lithium reabsorption, because hyponatremia means there is decrease in the sodium filtration, there is less sodium to be reabsorbed, and that's why there is increased lithium reabsorption. So in hyponatremia also there can be lithium reabsorption, increase in lithium reabsorption, which can lead to lithium toxicity. Okay. Now, what are the side effects of lithium? So, we have varied side effects of lithium. First is CNS side effect. So, lithium, just like sodium, it will enter into the brain, and most common side effect of lithium in therapeutic dose range is fine postural hand tremors. Okay, so that occurs in therapeutic dose range. Another is that at peak serum calcium levels, again therapeutic dose levels, there will be cerebellar signs like ataxia, incoordination, slurred speech. So because of these signs and symptoms, patients' day-to-day activity may be affected. So these can be avoided by giving the dose at night, right? So during the night when the peak serum concentration level will be there, then the person will not even notice about these side effects. Okay, another side effect is weight gain. Okay, now if the serum concentration of lithium goes above 1.5 milliequivalents per liter, then we start getting the moderate CNS toxicity, and if the serum levels cross 2 milliequivalents per liter, then we get severe CNS toxicity. So moderate CNS toxicity, the symptoms are like that, similar to what we have seen, but obviously in this we saw that at peak serum concentration level only these are happening, but when the serum concentration goes above 1.5 milliequivalent per liter, then these increase too much. There can be even presence of seizures, and instead of fine tremors, there will be coarse tremors. Okay, then severe CNS toxicity occurs when serum levels increase to more than 2 milliequivalents per liter, and now there will be changes in the consciousness. There will be delirium, confusion, and coma. Okay, so what is the treatment of this? Well, there is no specific antidote for lithium toxicity. You have to provide supportive treatment, and dialysis needs to be done to remove the extra lithium levels, just like electrolytes. Okay, so dialysis will remove the extra lithium levels. Then we have renal side effects. So renal side effects again occur because lithium is being reabsorbed just like sodium. So in the principal cells, in the collecting duct, we have this ENaC. Okay, epithelial sodium channels are there. Now normally sodium is getting reabsorbed from these channels, but lithium also can enter via this channel. But once lithium enters into the cells, it is not transported by sodium potassium ATPase. So sodium can bind to the sodium potassium ATPase, but lithium, that doesn't happen. So there is increase in lithium concentration within these cells, right? So there is accumulation of lithium within these cells, and this causes the down regulation of aquaporin 2 channels. What is the role of aquaporin 2 channels? Well, our vasopressin ADH, so ADH receptor actually acts on V2 receptors here, and this causes increase in CAMP, ultimately causes here fusion of the aquaporin 2 channels. Now because of the down regulation of aquaporin 2 channels, this is not going to happen, and if this doesn't happen, that means water is not going to reabsorbed with the ADH. Okay, so ADH action is not going to take place. So this is known as vasopressin insensitivity, and this basically causes polyuria, and because of excess water loss, since water is not getting reabsorbed, the person feels thirsty too often, so that leads to polydipsia. Okay, long term if it is given, then it leads to nephrogenic diabetes insipidus. It can cause nephrogenic diabetes insipidus. And what is the treatment? Give amiloride. Amiloride is a diuretic which blocks ENaC channels. So lithium absorption is not going to take place, lithium accumulation in the cells is going to decrease, right? Then we have other side effects, that is the thyroid and endocrine effects. So there is decrease in T3, T4. So lithium can lead to hypothyroidism and goiter. Then it can also cause hyperparathyroidism. Okay, so there is hypercalcemia. Actually that, that calcium acts on the parathyroid gland. Okay, and because of calcium there is decrease in the release of the parathyroid hormone. So calcium is acting in a negative feedback manner. Calcium is decreasing the release of the parathyroid hormone. Now with lithium, this set point for action of the calcium is increased. So same calcium which was causing decrease in the parathyroid hormone release, that is not able to act on the calcium sensing receptor. This is calcium sensing receptor, that is not going to happen, and hence there will be increase in the PTH secretion, which further will lead to increase in the blood calcium levels. Okay, so those are the endocrine effects. Then we have heart. In heart, what we see that if we take ECG, there is depression of T wave. Well, it is not harmful, it is a benign condition and it is reversible. However, at higher dose, at toxic dose, sinus bradycardia and AV block can occur. Okay, then it causes increase in the WBCs, right? Because it causes proliferation of the pluripotent stem cells. Okay, there is increase in the stimulating factor, granulocyte stimulating factor, there is proliferation of the stem cells, and there is increase in the WBCs. And lithium is contraindicated in pregnancy. Very important, it is contraindicated in pregnancy because it can lead to cardiac defects, that is Epstein anomaly in fetus. Epstein anomaly is what? It is tricuspid atresia. Okay, so it is contraindicated in pregnancy. So if the patient is suffering from bipolar disorder, so drug of choice for bipolar prophylaxis in pregnancy is antipsychotic. We don't give lithium. So with these many side effects, it is important that routine monitoring is done for various parameters. What is this? One is lithium serum levels, because it is a drug which has narrow therapeutic index, narrow safety margin is there. So routinely we have to monitor the lithium serum levels, we have to monitor the WBC counts, we have to monitor renal function tests. Patient should not go into nephrogenic diabetes insipidus. We have to monitor T3, T4 and serum calcium. T3, T4 easy to manage if the person becomes hypothyroid. In that case, drugs can be given externally, but we have to monitor so as to catch it earlier. Then we have to do ECG in older individuals and also in patients with arrhythmia and coronary artery disease. So when the patient is on lithium, we have to monitor for all the adverse effects of lithium. Okay. So that was about the mood stabilizers. We saw the drug of choice for acute mania and also for prophylaxis in bipolar disorders. And we also saw in detail about the drug lithium. If you like the video, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.